I would like now to introduce our next speaker, Professor Anthony Redmond. For the emergency physicians in this audience, Professor Redmond should not be a stranger because his book on the lecture notes on accident and emergency medicine, and also the Oxford series, you all have before you prepare for your examination. So this is here now in person. Okay, actually, Professor Redmond is now the Professor of International Emergency Medicine and Deputy Director of the Humanitarian and Conflict Response Institutes at the University of Manchester. He also is the Director of UK Med, which hosts the UK International Emergency Trauma and Medical Registers. So this is how the UK has established registers of people who are competent to do emergency work internationally. And this will be, like Dr. Perseri said, a more sort of concrete example of how this can happen in the UK, for example. Are you okay? So let's welcome Dr. Redmond, Professor Redmond in the usual manner.
While I find my presentation, which isn't there, just by way of a link with the last speaker, two interesting observations. In the UK, in England, the use of the term humanitarian came into common usage with the abolition of the slave trade, when people came together to help humanity. There were religious people, there were non-religious people, there were politicians, there were non-politicians, but they came together collectively to address this terrible human rights issue. But intrinsic to the response was that of change, and that they wanted to change. So there was a humanitarian need, there was something that needed addressing, but integral to the response was a change that would ensure it didn't happen again. And I do have concerns that we tend to lose sight of that and think that humanitarian response is just doing the immediate emergency response, when if we are true humanitarians, we will be asking, why did it happen in the first place? And how do we stop it happening again? Because I'm quite keen that we move away, for example, from the term natural disaster. There are natural phenomena, but the disaster has a human element. Something has gone wrong. And if you look where the disasters occur and who's most affected, it represents their vulnerability. And the poor are the most vulnerable of all. And poverty is a function of politics and economics, as far as I'm concerned. And why is that important? Because you can change it. So I think we have to extend it. And the other observation I would make, because both Henri Dunant was mentioned and Florence Nightingale. Florence Nightingale did not like Henri Dunant. She thought, and she wrote a number of letters to him, saying she thought the concept of the Red Cross was wrong. Because, she said, if you provide assistance to the victims of war, you are relieving the combatants of their duty to look after the mess that they've caused, and they will actually carry on fighting. Now, that argument, and I understand, and it's a difficult one because there is an imperative to help, continues. Bob Geldof, who you probably will, you might know, who did the Band-Aid response to the famine in Ethiopia, got very upset when it was said that by helping feed the people of Ethiopia, he was allowing the country to pursue the war, and he got very cross. Well, that might have been the case, but they still needed feeding. So these arguments go back right to the inception of humanitarianism. Anyway, I will now talk about what I came to speak about, which is foreign medical teams and the lessons from the UK. Okay, this is where we are at the moment in the United Kingdom. This is our national response framework. And you will see now we have UK emergency medical teams. This is the programme. This is the national response, with a national steering group, with 2 government departments, the Department for International Development, the Department of Health, my organisation, UK Med, which is housed in the University of Manchester, Save the Children, it's a big international NGO, and Handicap International. This is the consortium as it exists at the moment in the UK to launch these national emergency medical teams. And we have 4 strands to our work. We have registers of personnel, and I will discuss those in some more detail. So those healthcare workers in the UK who wish to respond to disasters and emergencies overseas can come forward and register. And through the registers, we can map the assets, we know where people are, but we can make sure that these people are appropriately prepared, are appropriately trained, and that we have an on-call rota so as they can deploy as quickly as possible. And importantly, we can make sure, for example, that they're properly insured. People often don't think about that, including medical indemnity. You have to provide the same rights to those patients that you are treating as you give to your own patients at home. And in the UK, we cannot practice unless we have medical indemnity. So we have a medical indemnity programme that extends beyond the UK, for which the government pays. And also, you have to have authorisation to practice in that country. That's often forgotten, I'm embarrassed to say, but and it's always a good question to ask if somebody says, oh, I volunteered and I went and I did surgery in some place and all that. You say, oh, that's interesting. How did you get on the medical register there? And then wait and see. Because it's important. It's a legal requirement. And the more vulnerable the country, the more vulnerable they are, the more in need of international help, the less likely they are to have a mechanism to enforce that for foreigners coming in. But the responsibility is on you. You make yourself accountable. You make yourself authorised to practice. We have a specialist deployable surgical platform, really based around earthquakes, and a specialist surgical team that will deploy. Physiotherapy and rehabilitation expertise, a very important part of the response. And from our experience, given the distance the UK is from the part of the world where most disasters occur, by the time we get there, the gap that we can fill is more likely to be around rehabilitation, specialist rehabilitation, spinal injury management, because many vulnerable countries don't have that to any great degree, either not at all or to any great degree. So we can actually provide that. And then specifically to work with the World Health Organization and the Foreign Medical Teams initiative that is being developed. It's established now and is developing further. So these are many of the disasters of the last 25 years, and I think I've been to all of those and more. But I want to discuss 2 important ones. The first earthquake I went to, the earthquake in Armenia, and then Haiti, which has already been mentioned, actually caused people internationally to reflect upon their practice. So what was important about the earthquake in Armenia for the international response? It was probably, or it is said, that it's the first time there was a real large international response and many teams being invited into a country. Good-hearted, good response, but a recognition that so much of that effort would have been far more effective had there been some coordination, had the country receiving that aid knew what they were getting beforehand and could have exercised some choice as to what was and what wasn't needed. Very much as we recognise now, this idea that people still say there should be coordination. It's a very good point made by Sachin. Unless you understand the system, you won't know that there is a coordinating mechanism, because after the Armenian earthquake, the United Nations Disaster Assessment and Coordination Team was established. There is a mechanism under OCHA that as soon as an event happens, this UNDAC team, I was a founder member of the UNDAC team, will send a small team out to work with the local authorities, identify what the needs are, disseminate them, and then the response can be targeted, tailored to what's actually needed, because it's very important when we respond, we give what is needed, not what we have. And there is a difference. And it might be that what's needed is not what you have. Well, that's fine. Don't go. Also, the International Search and Rescue Advisory Group came out from that. Very important for search and rescue. And they actually made better progress than we did in the medical profession in terms of registration, classification, accreditation, training and retraining of teams. They got off to a bit of a slow start, but then they caught up. And the medical teams lagged behind that. But what's ironic about it is that whilst they are very professional, the search and rescue teams, international search and rescue, given the time it takes to get there, and if you take, for example, the UK team, how far away we are, you have to recognise that most people who are rescued by fellow survivors, the rest by people in the immediate environs. If there's an earthquake here now, heaven forbid, and this building comes down, if we are going to be rescued, we will be rescued by those around within the building who are not injured, and certainly those immediately around, and then the local fire and rescue services. We will not be sat around waiting for a team from Manchester to come and sort our problems out. And it's very important that we recognise that in terms of the time. We have a very good, I'm very proud of our search and rescue team in the UK, but we have to face up to the realities. Do you know, for example, or could you guess how many lives the UK search and rescue team saved in Haiti? It cost $1 million to send a team of, about 70, I think, in the end went. How many lives they saved? Just hazard a guess. 10? 300? 10? It's like one of these quiz panel games, isn't it? High up, look, 150. Three lives saved. Was that a good response or a bad response as far as the UK team is concerned? It was their best response. It was their best result. We're too far away. We have a great team. They are very skilled. And there are other things that they can do when they're there, of course. But in terms of life saved, the search and rescue is, international search and rescue is very limited. And yet they're very well organised. Skipping forward from Armenia, what came out of that, we've got the earthquake in Haiti. Now, we've heard some of the issues around that. We deployed with Merlin, which is a large UK NGO, and worked with Handicap International, and we established a field hospital in Haiti. And the team was there, all in all, for almost 3 months. And then 3 months after that, I took off my NGO hat and I put my university cap on, and we went and we did a research project, a qualitative and quantitative study of the impact of foreign medical teams. And amongst the findings were the following. The amputation rates for foreign medical teams coming in ranged from 5% or less for some teams to greater than 45%. And a subset of that team that was, there were a number of components to it. One component of that team was amputating at the rate of 85% of the patients that they see. Now, this is the same patient group. I know there will be differences. And there is a debate to be had about amputation in these circumstances, because if you want to avoid crush syndrome, you want to avoid sepsis, then you will amputate. And then once you've amputated, then there will not hopefully get any of those complications. However, you've amputated. It's a one-off decision. It's done. And in a vulnerable person, in a vulnerable country, that can be an absolute devastating operation that you've done. So you do limb salvage. But limb salvage requires several procedures on the one patient. And while you're doing that, there are other patients might be getting no treatment. It's a really difficult problem, and we need to address it as the medical community. However, it's only the experienced team are making any records at all. Teams made no medical records. So I don't know why they did what they might have been right. It might be that the ones amputating at a low rate maybe are missing and should be. I can't tell you. We need, and this is a professional issue. You have to make medical records. You have to get not just informed consent, you have to get consent. But many procedures were done without any consent whatsoever. And also, no integration. This is actually not taken from Haiti. This is taken from another earthquake that I went to. But you have to integrate with the local authorities. Here, a team had done fasciotomies to release the pressure in a crushed limb, made no medical records about this. They were then put into a local hospital, so there's no records. People don't know what they've done. The local hospital had no experience of managing these things, and so they sewed them up. So they sew up the fasciotomy. So what could have been a limb-saving procedure has now ended up as a life-threatening complication. And they went on to have an amputation. Because it's the first time I'd seen in my practice actual gas gangrene actually bubbling in the tissues. And what a tragedy. We see guillotine amputations done as the only surgical procedure. Now, that shows that the person who did that has no surgical training. You would know how to do a fish mouth closure if you'd had the most basic of surgical training. That's a dreadful thing to do, to just do a guillotine amputation and leave this raw stump there. It's wrong. And we have seen that repeatedly in earthquakes that I've been to, where it's clearly the person doing the amputation has no surgical training. And in Haiti, some of the amputations I saw, I doubt they'd had any medical training. And in case you're thinking, well, you might have to do a guillotine amputation to release somebody who's trapped. Yes, you might. It's actually very rare, because if they've been absolutely crushed and trapped to that extent, it comes away really quite... I mean, I have taken away the bit of tissue that was holding it. I wouldn't class that as an amputation, but it's... so it's actually very rare to do it. And even so, if you do it, you should then close it over or refer the patient to somebody who can do it. And so there are issues around amputation. Harvard Humanitarian Initiative, a humanitarian summit, this was addressed a few years ago by consensus guidelines. And this has been a great step forwards that bring the communities together. Let's agree what is the best thing to do. But at the moment, we only have consensus guidelines for things. We need to get some proper evidence-based medicine into it. And to start that, we need people to make medical records, to get the data, have a minimum data set, and to share their activities. Because NGOs are not very good at that, at sharing with other NGOs the true level of their activity. I've heard, somebody once said to me, oh, it's commercially sensitive. Commercially sensitive. No, it's not. It's about medical audit. You should practice everywhere in the world to the high standards you have in your own country. Now, the British government, after Haiti, carried out a humanitarian emergency response review, which you can download from the internet. If you Google HERR and DFID, it's actually, for a government report, it's not a bad read. Although I just may be a very sad person, but I did read this in bed when it came out. But it's actually quite readable. And there are many conclusions in it, but they actually analysed the cost of sending medical teams and the cost of sending the search and rescue teams. And they concluded this was the government health economists, so quite, detached and objective, and they were only looking at lives saved. And that has limitations. That wasn't my parameter that I chose. That was what they did, and they looked at this. And they concluded that for the British government spending money, medical teams were at least 100 times as cost-effective as sending an international search and rescue team. Cost less, stay longer, treat more people, and save more lives. And that was picked up by the government itself, and as part of their recommendations that they said will now come into policy, we will retain the capability to send search and rescue, because we don't want to throw the baby out with the bathwater. We have a good search and rescue service. But we'll complement this with areas where we think the UK can help. And one of these was a surgical team. So that helped us enormously. We've been doing this work for a long time, but now we've got official government support, and we could set up the UK International Emergency Trauma Register. And we've set this up as a national asset. It's hosted by my organisation, UK Med, within the University of Manchester, but it's a national asset. It doesn't belong to me. I administer it and run it. And through that, this register has, it maintains the current availability of those on the register. We do pre-health screening, and yeah, I think I can go on a bit longer because there's, we're sort of splitting it into two and then take the questions. But it can ensure deployment. We set it at 24, 48 hours to start with, but we want to get that down to 12 to 24 hours. We liaise with fire and rescue, and we run a series of training courses. And the purpose of the register was to facilitate recruitment for NGOs. We have Save the Children, MSF, Red Cross, VSO, all this come to us, and they can draw down from the register surgeons who come pre-packaged, or physiotherapists. They're insured through us. They've done our pre-deployment course and so on, and they will then work within that organisation. They work for that person, but they come through us. But also, we can facilitate the national response. So the healthcare workers, for any official UK PLC response, the healthcare workers are drawn from us. And we have trainings. We have a core pre-deployment course that everybody does. We have a surgical training for the austere environment. And what I've been very keen is to get this training done by those who would normally do the training. So if it's surgical training, well, in the UK, that's the Royal College of Surgeons. So let them train the surgeons. We have a course with the Royal College of Anaesthesia. Let them do the training. For our physiotherapists and rehabilitation experts, that's organised by Handicap International. Let the experts who do that do it. Because I want to, although this work occurs in highly abnormal circumstances, we have to normalise it. We have to make, that people are professional, they are accountable, they are properly trained, they are qualified in the same way that they do in their normal work. And we are working with the Royal College of Surgeons of Edinburgh and their Faculty of Pre-Hospital Care to also have a pre-hospital emergency medicine course. All these courses for the austere environment. So people already are qualified as emergency physicians, qualified as physiotherapists, qualified as surgeons, but it's the next step. How do you apply that in the austere environment? So the surgical course is a cadaveric course. We have the chief surgeon from ICRC, chief surgeon from MSF come, our surgeons, and they make sure that everyone uses the standard external fixator. This is the approach to amputation. This is how head injuries are managed, and so on, triage, and very practical to make sure everybody is as well that, because surgery is so specialised now, that every surgeon can put an external fixator on appropriately. Everyone can do a basic flap, and so on. It's, and also we have overseas training. We want people on our register to understand the importance of being able to work in another environment, in somebody else's hospital, in somebody else's, under somebody else's authority, still maintaining and working with your standards, but the system will be different. And to recognise systems are different, and you have to work to that. And you can get experience of that, and also you can establish very good relationships. with these countries as part of a training exchange. So our UK response for trauma is around a core surgical team. It's like concentric circles then around that: emergency medicine and specialist nurses and physicians. And then the logistical support did come from Merlin. Merlin has now been absorbed into Save the Children, and so that's our logistical wraparound, and working with Handicap International for the long-term follow-up. Okay, what happened internationally after Haiti? We had the meeting of experts in Cuba, and these were the concerns. So we had people from MSF, Red Cross, all there, and this was agreed. These are the issues we have to address: accountability, quality control, coordination, reporting, and specifically clinical competency, record keeping, and the follow-up of patients. We have to get that addressed. And to do this process by process of registration. We do it in the UK. Spain has a register. Many countries have registration systems. So systems. Let's look how this WHO can facilitate this at an international level, and to see registration as the first step on the road to quality assurance. Our two first work themes: classification and standards, and monitoring and reporting to the local authorities. But I want to draw your attention to the Blue Book, Classification and Standards, which you can download from the Foreign Medical Team's website. This came out in the July, and in the November, when we responded to the Typhoon Haiyan in the Philippines, they were already applying the classification and standards. And it caught on so quickly, and we're very appreciative of the buy-in we got from the Philippine authorities at that time, because it took it to a much wider audience and gave it credibility so early on in its genesis. So further steps that we're looking to do with the Foreign Medical Team's working group is get international guidelines, look at how training courses are established and developed in each country, data collection. Have I said it enough times now about data collection and methods of reporting, and accreditation? If you look at the classification and standards document, FMTs, foreign medical teams, they're probably now going to be called emergency medical teams. But for the moment, let's just stick with FMT, because that's what it's called on the website. Type 1 is delivering primary outpatient care or mobile clinics. Type 2 is Type 1 plus an inpatient facility. And Type 3 is Type 1, Type 2, and then plus that, the full field hospital independent capability. And then also specialist cells. Now, the registration process at WHO is open. We have registered, and we have registered at this point in time as a Type 2 with specialist cells. We have ambitions to be a Type 3, but we would sooner under-declare than over-declare, so as countries know what they will be getting from the UK, and they will not in any way be disappointed. I hope they actually might be quite pleased that they're getting more than we have. But I do think it's important that people don't oversell themselves, because this is about countries receiving the teams being able to know what they're getting and place you appropriately. They might not need you, and then if they do need you, they will know where they can best place you, what you will be able to offer. Because the aim is we want, through WHO, each country to have a national register, only deploy registered teams, only receive registered teams, have regionally based teams. Hong Kong, China, so important geographically to have such an influence and to show leadership in this area, because what we need is that the response to disasters to be guided by the experience of disaster-prone countries. At the University of Manchester, we're just completing the process of becoming a collaborating centre to support the Foreign Medical Team's initiative and to integrate that into capacity building, and to do research. And I very much hope that as part of this process, we will collaborate with the DPRI here in Hong Kong and IMDR also in Chengdu to triangulate this process, because I cannot emphasize enough the importance of leadership in this area being taken from this area. And we want to work towards a standard curriculum. There will be different elements to it and needed in different parts of the world, obviously, but there are some core values and some core skills that we need to get in, which are universal. Just moving on quickly to just say how it then developed further in the UK. I mentioned Typhoon Haiyan that we responded to from the UK International Emergency Trauma Register. But what became clear to us as well, that whether it's the basic need is for surgical expertise, whenever a vulnerable country has had a catastrophe, then the whole health system is affected, and you need as well to provide primary care and community-based care and put that in. We responded after that to Gaza. Again, you might think, well, that's a pure trauma response. Well, yes, we sent out our trauma team. We now make sure that rehabilitation specialists are in our forward team to start the assessment and the need for follow-up. And, of course, what was needed in Gaza after the initial management of the trauma was the follow-up of people with amputations of chronic wounds and in their home. And working with Handicap International, there was a 6-month program to build capacity in Gaza in this area. It's so often forgotten. To think, the excitement, I was going to say glamour, but I think you know what I mean, of the surgical team, is often drowns out what the real needs are and what benefits an international team can give to a country that might not have those longer-term rehabilitation facilities. And so we did on-the-job training. And incidentally, something that we did after the earthquake in Sichuan, the management of spinal cord injury and spinal cord injury in the community was a recognized needs recognized by the local authorities, and we rotated spinal injury staff from the UK spinal injury centres into Chengdu to do training for people, quite basic training. I remember seeing a wonderful demonstration of how a paraplegic person can get themselves in and out of a car without assistance and so on. And that programme went on for almost 2 years after the earthquake. To draw to a close, we all know about the Ebola response, and the UK wanted to mount a national response to that because we had this system whereby we could draw healthcare workers from the National Health Service and get them trained, insured, and so on. We were asked by the government to establish a medical register for non-trauma, non-earthquake things to broaden our expertise, and that's what we have done. We ran the UK national response, the medical part of it, to dispatch people to Sierra Leone, working with a whole range of NGOs, including Emergency, I think, who are here, and Save the Children and IMC and so on. And we went through a similar process of people applying to the register, being shortlisted, having an interview, Ebola information evening, where we gave them very hard facts about the risk that they were taking. You will know that one of our nurses contracted Ebola and then was ill again recently. I'm very pleased to say she's on the mend, and what an admirable and wonderful person who has said to us that in spite of everything, she's glad she did it. And I think the word that we need to not be afraid of mentioning in this context is altruism. Human beings know and show altruism. We do health clearance, and we work with the NGOs, and then we went into Ebola treatment centres. And we had, without a recruitment program, just the chief medical officer went on the television and said, we are thinking of sending healthcare workers. and UK Med will coordinate it. We had to close it at 1600. We had more than we needed. And finally, my organisation now is changing significantly. We've been asked by the government to have 3 registers. We've got the trauma register, we have the medical register. I'm working with Public Health England, the official public health body, a public health register, and UK Med to broaden itself into a community of practice, to draw healthcare workers in, looking down the left, this community of practice, a membership network to get these principles out, get people prepared, get people trained, to work. Now for us it's NHS Trust, they're the employers, to get people released from their work, to get this into people's job plans, get it into their CPD so that it's recognised as an integral part of what they do and the benefits it brings back to the UK. I've pointed out to ministers at home, because of the Ebola response, we have a whole cadre of healthcare workers who have direct experience of managing dangerous pathogens and treating patients in those circumstances. And also get information out, do lobbying, tell people and share our experiences with others. And also now to consider and prepare for going into conflict and post-conflict areas. At WHO, the Foreign Medical Teams Initiative, registration is open for your teams. And if you want any assistance with that, please come and speak to me. And where are we up to? We are now, I've just advertised for our first humanitarian post in the NHS, funded by Health Education England, so the training organisation, to get this into, as I keep saying, to normalise the practice of this. We're working with the Royal Colleges to establish an accredited training programme and an exit qualification, and who knows, we may have a subspecialty for this. Thank you very much.
Thank you, Professor Redman, for this very informative talk. May I invite all speakers now to be on stage for the open discussion? Any questions and comments from floor? Dr. CB Low? CB? Có mic à? Có một mic. CB.
Thank you very much for your very enlightening talk. May I have a question for Professor Redman? You mentioned about indemnity and insurance. For indemnity, it usually compares to standards. So there must be a difference in standard between the of the medicine in UK and the country you're going to. So especially, not to mention that in that austere environment, when that country is suffering. So when you talk about indemnity, which standard will you observe, or will there be a pledge for a third international sort of standard to provide care in austere environment in that country? And the second question to follow up is the insurance. Which insurance company is willing to cover that? If it is MPS, will there be a need for a top up of the?
Okay. I'll answer both those questions. The standards one, you work to the standards and the competencies that you are qualified to do in your own country. You do that wherever you go. The standards are the same. Now, and if you say, well, I don't have many resources, well, that is a standard issue because you should take the equipment with you. If you are deploying, you have to make sure that you have the appropriate equipment, that you are self-contained and you can do this. So it's quite a short answer. There's only one standard, and that's the proper standard, and you do that. And yes, decision-making can be difficult when you've got lots of casualties and they are presenting to you, but there's still the standard, you know, of doing medicine to the best of your ability and to what you are licensed to do. With regards medical indemnity, that drives standards as well, because our insurance companies only cover us because they see the training that we do and the standards that we adhere to. So that's important. The insurance company, it does cost money. And I'm very grateful to the British government for funding that, but they are insistent that have proper insurance and medical indemnity. It's a consortium that does it. I went to the Medical Defence Union, who wouldn't insure us, but they put me in touch with their broker, who actually, so this is a bespoke policy that we worked on. And incidentally, don't be too put off by it, because the more people are involved in it, and the more it's actually, our premium has stayed the same from when we first started, because we can repeatedly show to the insurance things that we have deployed, and we deploy repeatedly, and we keep to standards. And that, so although our numbers are increasing, our complexity is increasing, our premium so far has stayed the same. Thank you.
Emily.
First, let me start by saying thank you, Tony, and also Sajid, for the wonderful presentation. Actually, along the same line about coverage, it's good to understand how medical health professionals are covered from the insurance point of view. But how about the other side, the malpractice? I mean, I want to understand from your experience and your vision, how could we ensure some kind of protection it's also conferred for the patients? It's true, standard is the first line, but what if someone really malpractice for whatever reason? I mean, currently, do you envision it would be managed by the home team, home community, or like, is there some form of like a whistleblower or some kind of system that can manage that as well?
It's a very good point, and I remind all. Well, first of all, we all our members have to adhere to the standard codes of practice, which you covered, but also we have rules of engagement for us, and that is that we remind them that they are accountable to the Nursing and Midwifery Council, to the General Medical Council in the UK. And if you practice inappropriately, wherever you are, the General Medical Council still holds you to account. So when I was setting up the register, I worked with the General Medical Council to make sure that so you are accountable to that. And also, you mentioned whistleblower, the same onus is on you as a professional to expose a colleague who is not working appropriately. So we adhere to the same way it would be in the National Health Service to wherever we are in the world. And also, they will equally be accountable to the local authorities. You're not in a bubble, but we emphasise to our members, but you are still accountable to the home. We are in a peculiar position with the National Health Service, and they themselves, the NHS, are very conscious of the reputation of the NHS. So for the Ebola response, they too insisted on standards and how people were practicing. So, Sajid.
So I think the opportunity for engagement or intervention there for malpractice, essentially, given that there isn't legal recourse, which is what you're hinting to, will be at the point of entry, right? So as you're negotiating entry into a country, and right now that is still very skewed, right? You're still kind of in this, as Professor Redmond pointed out, the hapless recipient, which we're trying to desperately and briskly move away from. If those systems are in place to receive people, that's where you can negotiate what the accountability is going to be. In the absence of that, as in Haiti, people don't have legal recourse, and that is a problem. Your home institution can hold you liable, but if you're a poor Haitian, what are the channels?